Okay, so today we continue with our discussion of abnormalities that we can see through the emergency room. So starting with this case, you can see that this patient is a nice example of a thoracic aortic dissection. So when we do the dissections and we give intravenous contrast, depending on what vessels you're doing at, whenever you do vascular angiography studies, you need to be able to time the acquisition of the imaging to when the contrast is in the vessel you want to evaluate. So if we're looking at the thoracic aorta, GE calls it smart prep. Essentially what this is you take a location, one slice location, you localize it, and then you decide, on your vessel of interest, here is the thoracic aorta, and then you would put a region of interest around the vessel, either the ascending or the descending thoracic aorta, small region of interest, and we take a series of low-dose images at that one location as the contrast is going in dynamically. And then within that region of interest, the software looks to see what the attenuation is as the attenuation is increasing. And once it hits a particular threshold, then that triggers the scanner to start scanning from the beginning of the acquisition to the end of the acquisition. And so this is how we can time the acquisition when we're actually scanning the patient when the contrast is in the vessel. So if we're doing a dissection study, we want to time it for the thoracic aorta, so you put your region of interest over the thoracic aorta. If you're doing a pulmonary angiogram study to rule out PE, you would localize the main pulmonary artery and put the region of interest over the main pulmonary artery to time the acquisition for the pulmonary artery. So this is called smart prep with GE. Other vendors have different names for it, but the way it's done is dynamically at one particular location until the contrast arrives. Now in this particular example, we have a nice example of a type B dissection, and you can see the entry tear here is very well demonstrated on the sagittal reconstruction. So here's the false lumen, here's the true lumen in here. And then there's also this little outpouching over here. Here's the false lumen out here. What does that outpouching represent? Yeah, so in this case, this is actually coming off the way the dissection is propagated here is that ductus diverticulum is coming off of the false lumen because of the way the dissection itself is propagated. And so in these classic type B dissections, they tend to start right here, right at the origin of the left subclavian artery. So what happens is the entry tear is usually somewhere in the descending thoracic aorta, and the dissection propagates. So it propagates forward down as far as it tends to go, but it also propagates retrograde, and that retrograde propagation seems to stop in many cases right here at the origin of the left subclavian artery. So the entry tear causes the dissection and then propagates in both directions. And with the classic type B, it stops right there at the origin of the left subclavian artery. Now, when we are assessing dissections by CT, the things we want to decide, first of all, what type of dissection is it? Is it a type A or a type B? Typically, how do we differentiate that? What differentiates a type A from a type B? Yeah, so that's the classic teaching. If the ascending aorta is involved with the dissection, it's a type A, and if the ascending aorta is not involved, it's a type B. You also want to assess the entry tear location. You want to assess the extent of dissection. You want to look to see if there's any great vessel involvement. Does it extend into branch vessels in the abdomen? And is there any compression of the true lumen by the false lumen? Are there any fenestrations along the dissection in addition to the entry tear? Are there other tears along the dissection flap itself? Because that can tend to keep the false lumen open. Wherever there are those tears, those fenestrations within the dissection, that will keep blood going into the false lumen to maintain patency of the false lumen. The measurements that you want to include in your report, the aortic annulus, sinuses of Valsalva, ascending aorta, aortic arch, descending aorta, abdominal aorta, and you want to look for the maximum diameter, including the true and the false lumen. These here in red, these are most accurately measured on your coronal reconstruction. So the aortic annulus is this region right here, where you see the insertion of the aortic valve here. Here's the left ventricle, so that's the aortic annulus. The sinus of Valsalva, these areas over here, just above that, okay, that's where the coronary arteries come out. So you take a measurement there, and again, these measurements are most accurate on these coronal reconstructions because the axial images will tend to overestimate what these diameters are. Same thing is true of the ascending aorta. Okay? So you'd want to get a true cross-sectional measurement there of the ascending aorta. And the aortic arch. The aortic arch, the descending aorta, abdominal aorta, these can also be seen or fairly accurately measured on the axial images once you get to those levels. So when we get to the level of the aortic arch, descending aorta, and aortic arch you want to look at both ways in different planes, but the axial images are often good enough. For the descending aorta, abdominal aorta, this is pretty accurate in the axial plane unless the vessel is very tortuous and kind of moving in and out of the slice. So, in this example here, what kind of dissection is this? First of all, what's involved with the dissection? The dissection involves what?
Descending.
It does, yeah, certainly involves the descending aorta.
Like the arch and maybe a little bit of the ascending.
Well, it does involve the arch. The ascending aorta is over here, though, right? So it doesn't seem to involve the ascending aorta. So this is a dissection that involves the arch, right? So what kind of dissection is this? Is it type A or type B?
Type B.
Yeah, so these dissections with arch involvement do not necessarily need surgical management. That's the major decision you're trying to make, right? Does it require surgery or not? And so this is a type B dissection with arch involvement. So this is not always covered in the textbooks. What happens if you have, your classic type B usually begins distal to the left subclavian. But what happens if you have arch involvement without involvement of the ascending aorta? Well, that's a type B with arch involvement. So these also tend to be are managed medically and not managed with open surgery for these type of dissections with arch involvement. Yes. Yes.
Just to ask you.
This one or this one?
Yeah.
Okay. Yes, that's a vessel, yeah. That's probably the left subclavian. No, this is not a tear here. The tear is here. So where the arch is defined as where the vessels take off, where the great vessels take off. The ascending aorta ends where you get the where you get the takeoff of the right brachiocephalic artery. Okay, so where the vessels take off, that is the arch. Right, the ascending aorta is proximal to that. No, this is in the arch. That's the point. The point is this is arch involvement without involvement of the ascending aorta. The arch is not the same as the ascending aorta. The ascending aorta ends where you have the takeoff of the right brachiocephalic artery. Somewhere here, the right brachiocephalic artery is not in this image, right? But it's proximal to this. Okay? Okay, so what about this case? What kind of dissection is this? How would we classify this? Is this type A or type B?
Type A.
Type
So why do we think it's type A?
It involves the ascending aorta.
Yeah, so we could see here, here's the dissection flap, here's the ascending aorta down here. We can see some dissection flap and also some intramural hematoma even within the ascending aorta. So it does appear that this dissection does involve the ascending aorta. Where's the entry tear? Yeah, the entry tear is in the descending aorta. How should this be treated? So,
Surgery.
all right, so the patient, so you're saying the patient should go to open surgery and have a graft placed in the ascending aorta?
Mhm.
Okay. Well, that has recently been changed in terms of how we approach these kind of cases. So the tear is in the descending aorta and it propagates into the ascending aorta, okay? So now there's this new classification scheme that is proposed here by the Society for Vascular Society and Society of Thoracic Surgeons, because it's the entry tear, the location of the entry tear, that really determines how these patients should be managed. So the aorta itself is divided into these various zones that are numbered. I don't expect you to memorize the numbering of the zones. But the idea is that in terms of classifying the dissection, the first thing you want to note is where is the entry tear. If the entry tear is in the ascending aorta, then it's a type A. And then the second number here, the subscript, is the distal extent of the dissection. So if the dissection extends all the way down to region 9, then it's a type A subscript 9, type A 9 here. But what if the entry tear is in the descending aorta and the dissection propagates in both directions into the ascending aorta and then also into the descending aorta? So here they would classify it as a type B, the 0 indicating it does extend to the ascending aorta here, and then the 9 indicating the distal extent of the dissection. So why is this a type B? Why is this important? Because of how this can be treated. This does not require open surgery to replace the ascending aorta with a graft. This can be treated by closing the entry tear with a stent, with a covered stent. So by closing the entry tear with a covered stent, that prevents the retrograde flow of blood here into the ascending aorta, and eventually the expectation is that the dissection flap here will heal. Okay? And so in this particular patient, that's how the patient was treated. This patient was treated with a covered stent here, okay? And so the stent is placed there to cover the entry tear, and what happens, so here is when the patient presented, we can see the tear in the ascending aorta, here's some thrombus in this portion we can see contrast, and then after placement of the stent, here's the stent, so the stent covers the entry tear, you can see how this area now is thrombosed, and the false lumen there has decreased in size, as had its thrombosed, and 3 months later it's completely healed. Okay, so it's the location of the entry tear is very important to localize. If you can't tell, then it's a type I indeterminate. But finding the entry tear is important because that can determine how we can treat these patients. So this patient does not require open surgery. This patient was successfully treated with a stent graft. Okay. All right, so another dissection here. So we'll go through this a few times. So tell me what kind of dissection is this, and can you identify where the entry tear is? Yeah, so here, the entry tear is in the ascending aorta, so then this we would classify as a type A, right? So this would be a type A dissection, right? You can see it does extend to the branch vessel. You can see the discontinuity there in the dissection flap in the ascending aorta. So the entry tear then is in the ascending aorta. Here's the false lumen, usually larger than the true lumen, and you can see compression there of the true lumen by the false lumen. So this would be a true type A dissection, okay? So we can see the entry tear here in the ascending aorta. There's the false lumen there. And then you can see that it extends down. Here's the false lumen. Often the false lumen tends to go to the left side, so we can see the left renal artery coming off the false lumen. That's pretty common, while the right renal artery comes off the true lumen. Here we can also see the dissection flap extending into the superior mesenteric artery. Okay? So that's a true type A. So another patient here with a dissection. And this one, the dissection flap seems limited to the descending thoracic aorta, so this would be a type B. But another important thing here is notice how large the false lumen is and what it's doing to the true lumen. So the false lumen can compress the true lumen, and if the branch vessels are coming off the true lumen, that can be a problem, especially if the mesenteric vessels are coming off the true lumen. So this can lead to what's called malperfusion syndrome, where because of that compression, the blood flow through these vessels is limited, and so that can lead to ischemia of bowel. So how can this be treated if we have a malperfusion here because of compression of the true lumen by the false lumen?
Stenting.
Yeah, so here they would place a stent into the true lumen. The idea would be to maintain the patency of the true lumen and also to decrease the size of the false lumen and then eventually hope that the false lumen thromboses. So this patient is treated with a stent, and then you can see already what's happening here is there's some thrombus here that forms within the false lumen, and the stent helps to maintain patency of the true lumen. Now, what can maintain patency of the false lumen? Well, you want to close any, if you close the entry tear, right, then you're closing that communication between the true and the false lumen. But often there can be other fenestrations distally along the dissection flap. And where those openings are, where those fenestrations are, they can also lead to patency of the false lumen. So it's not unusual if there are fenestrations lower down to have retrograde flow coming up the false lumen here, where the proximal part of the false lumen will thrombose off, but you'll get retrograde flow that will maintain patency of the distal part of the false lumen because of fenestrations, because of openings of the dissection flap more distally. Now, what happens if you have malperfusion, but you have the vessel that is malperfused actually coming off the false lumen, right? In that case, what can they do? Well, one thing they can do is actually create holes in the dissection flap. And so to get the blood flow to go through, to get to that branch vessel coming off the false lumen, they would create more communication in the dissection flap to allow the blood flow to get there. Okay. All right, another patient with chest pain, we can see the aorta looks dilated here, and then we can see that this patient has aneurysm. You just see this big dissection flap. In this case, the false lumen is quite large. It has thrombus in it and also calcification. You can see how it's compressing the true lumen. This is actually more of a chronic dissection in this patient. You saw the entry tear there, and this thrombus and calcification formed because of the chronicity of this dissection. So differentiating the false lumen from the true lumen, you always want to be able to do that. Determining whether the dissection is acute or chronic also is something hopefully that the clinical information can help you with. Okay? So when you're trying to separate the true lumen from the false lumen, start where the true lumen is, especially on these multiplanar reconstructions. Sometimes it's easier to differentiate the true lumen from false lumen than it is on the axial images. So you just follow the true lumen here, and you can see it goes around to here. There you saw the opening, the entry tear. And then the rest of that is false lumen, where it's larger as false lumen. So follow the ascending aorta, that's true lumen. True lumen goes around to here, right? There, and then the rest of this part, that big part, then is the false lumen. So use the images in the other planes to try to differentiate the true lumen from the false lumen. Okay? Another patient with chest pain, obvious dissection involving the ascending aorta here and descending thoracic aorta. But there's another finding here that's important to note, and that finding is so what's the significance of that part of it? Yeah, so hemopericardium, right, especially if it's higher in attenuation than simple fluid. And so so in that case, then this does require surgery for repair. So the complication of dissections that involve the ascending aorta are that there are three complications that can result in instant death. And so that's why you, that often they need to be repaired to prevent propagation if those complications haven't occurred yet. But one of them is hemopericardium, right? Extension of the dissection causing bleeding into the pericardium, that's one. What are the other two?
Coronary occlusion.
Yeah, so which coronary artery is typically more likely affected by dissection of the ascending aorta? Well, you only have two choices there, so.
Right.
Yeah, it's the right coronary artery. The flap tends to, for whatever reason, tends to spiral down closer to the right coronary artery. So usually for coronary arteries involved, it's the right coronary artery. So those are two complications. One, hemopericardium. Two, involvement of the right coronary artery. The third complication that can lead to instant death is,
Tamponade.
well, that's from the hemopericardium, right? So that, we already covered that. Extension to what? Well, what else is connected to the ascending aorta? No, going down the ascending aorta. Aortic valve, yeah. And what will that do? That results in, yeah, severe aortic regurgitation. Okay, so that complication also can be death. So to prevent that, you need the ascending aorta fixed. Another patient with chest pain, you can see widening of the mediastinum, right? Of course, we're concerned about aortic problems. Oh, big dissection involving here, the ascending, descending aorta. Notice how the dissection flap comes down here very close to the right coronary artery. Okay, so the right more often involved than the left when we have these type of dissections. So this patient did require surgery to repair her dissection, and this is the follow-up imaging. Now, whenever you're doing follow-up imaging, so it's not unusual for these patients who have a history of dissection, have had surgical repair, to come back to the emergency room for whatever cause of chest pain that they have, and the ER will, because of that history of dissection, will order a follow-up study that you will have to interpret. Always important whenever you're doing CT on these cases for acute aortic syndromes or on a patient who has had surgery on the aorta, protocol should always include a non-contrast CT first. So the idea is when patients have had surgery, you want to be able to identify the surgical material, right? You don't want to be confusing this with contrast or contrast extravasation when you give contrast. So you want to know where the surgical material is, and this also helps you to determine what kind of surgery was done. So the non-contrast images are important. Where it's dense here, see that density here on the non-contrast images, that's the aortic graft material that has been placed there to replace that dissected portion of the ascending aorta. And then we can have pledgets that they put in here to reinforce anastomosis, to prevent bleeding through the anastomosis. Often you can tell the proximal and distal extent of the graft on the non-contrast images, right? So it's very important to get non-contrast images first. And then post-contrast, you'll see that they will repair the ascending aorta, but the rest of the dissection will still be there, okay? So you'll be able to see the dissection flap going through the arch, going down the descending aorta, and your job is to determine, hopefully you have the prior study, has it gotten worse, has it remained stable, etc. But the dissection, the remainder of the dissection will still be there on the follow-up CT scans. Okay? So follow-up imaging, here's the repair, this part here. It's not unusual to have a little bit of kinking where the graft is placed there in the ascending aorta, and then the rest of the dissection will still be there. Okay, so this patient presents with acute chest pain, and we do working up for acute aortic syndrome. We always start with a non-contrast CT, and this is another reason why we like to do that. So why do we like to do that?
You check for the hyperdense crescent.
Yeah, so there's the hyperdense crescent sign indicating intramural hematoma. Yeah, so this patient has an intramural hematoma here. This can be pretty subtle, okay? So that's intramural hematoma. So that's now this used to be thought that this was something separate from dissection, But now the current thinking is that there is some intimal injury that has caused some bleeding and thrombus here within the false lumen. So it's kind of on the same spectrum of dissection, only the false lumen is not pink in these cases. And so what can help you when you're looking at this is to narrow your windows. So on narrow windows, like you use for looking for blood in the brain, where we have these intramural hematoma, where you have the hyperdense crescent, is a little bit easier to see. So always do that. Looking for that intramural hematoma. And then these are classified the same way, type A, type B, whether obvious and whether or not. So on follow-up CT, the patient developed this. The follow-up imaging looks like this. So what's going on now? So for type B intramural hematomas, they're treated medically, just like dissections. Usually get a follow-up CT to see how it's doing. Is it progressing? Is it getting worse? Is it healing? So is there a problem here on the follow-up scan? What's the problem?
The pseudo-injury,
Yeah, so what do we call this?
penetrating aortic ulcer.
No, it's not a penetrating ulcer because this is a patient who had a pre-existing intramural hematoma and then developed this on a follow-up study, right? This is called, the term for this is ulcer-like projection, right? This is an ulcer-like projection. This indicates, again, that there's been some increased deficiency or increased injury or whatever here to the intima, right? Which is bad, okay? So then this needs to be followed very closely, or it may need to be treated, especially if it develops and gets bigger, because in essence this is a pseudoaneurysm. Right? So this is an ulcer-like projection that can be a complication on follow-up studies in a patient who has an intramural hematoma. And here it is on volume rendered images. Here's an angioscopy view, virtual angioscopy with CT. Showing you that this is a defect within the intima that is developed in this patient. Okay? So another patient with chest pain. Again, we can see the hyperdense crescent here. So we have another patient here with the intramural hematoma. You can see that. And then post contrast, you will see it, but it's the hyperdensity here on the non-contrast CT, which tells you that this is acute blood, that that's an acute intramural hematoma. Okay. So 8 months later, another patient also developed this ulcer-like projection within the intramural hematoma. So this patient has chest pain. And we can see another case of intramural hematoma there wrapping around the descending thoracic aorta. And in this time, when we look at that, we can see that there are some collections of contrast. See that? There's some collections of contrast there in the intramural hematoma. So are these ulcer-like projections? What are these? So what are these called? Yeah, so this is intramural, these are called intramural blood pools. And is the prognosis better or worse than ulcer-like projection? Better, yeah, better. These tend to heal on their own. So to differentiate this with the ulcer-like projection, it's a wide mouth. These have a very narrow mouth. Right? These have a very narrow mouth. These little collections here, these are called intramural blood pools, and often they come off here at the origin of vessels like the intercostal vessels that are coming off. So what happens is the intramural hematoma causes some expansion here. It does form like a little aneurysm there where the vessel comes off. But on follow-up studies, these tend to heal on their own. So the prognosis for these is better than the prognosis for ulcer-like projection. So these are called intramural blood pools. Well, hang on there. Hang on. All right. Anything wrong here? Yeah, so now what about this intramural hematoma?
It's also in the pulmonary artery
Yeah, so so we do have intramural hematoma here involving the ascending aorta, but there's extension to the pulmonary artery. Notice the narrowing of the pulmonary artery, and this can also be a complication of intramural hematoma if it extends onto the pulmonary artery, can actually narrow the pulmonary artery and can impair the flow of blood to the lungs. Okay, so how is this possible? Why does an intramural hematoma, it's bleeding in the aortic wall, how does that extend to the pulmonary artery?
They share an adventitia.
Yeah, so the ascending aorta shares the adventitia with the pulmonary artery. So if you have intramural hematoma within the ascending aorta, it can extend to the pulmonary artery. So it's important to realize this complication also of intramural hematomas. Another patient with chest pain, problem there, looks like a problem of the aorta. And so let's take a look. And our CT looks like this. So, what is this called? Oh, you see that pouch in there from the aorta, okay? And also the low attenuation surrounding it. What's that low attenuation? What is that stuff? Yeah, it's kind of a pseudoaneurysm. So that's intramural hematoma, right? And there's a part of the aorta sticking out here. See that? So this part of the aorta is sticking out. And then we have intramural hematoma surrounding that area, okay? So what is this called? This is the penetrating aortic ulcer, okay? So with the penetrating aortic ulcer, what happens is you have ulceration of a plaque that extends into the aortic wall, so that the contrast actually extends outside the aortic wall, just like an ulceration in the GI tract, and then you get intramural hematoma around it. So to differentiate this from ulcer-like projection, with an ulcer-like projection, what happens first is you get intramural hematoma, and then the ulcer-like projection occurs later. With penetrating aortic, and then often the intramural hematoma is more extensive, right? The intramural hematoma is a pretty extensive abnormality there. Whereas when we have a penetrating aortic ulcer, you have the intramural hematoma centered around the penetrating aortic ulcer. So this is it's kind of a pseudoaneurysm, so this is going to require, usually stenting to treat this. Okay? So that's the difference between a penetrating aortic ulcer and intramural hematoma. In any case, whenever you have contrast that's extending beyond the wall of the aorta, that means that there's a disruption of the intima, so that is a bad thing. Okay? That's usually going to require the vascular surgeons to address it. Patients who had motor vehicle accident, anything wrong? Oh, besides these guys over here, what are these guys? Yeah, we have rib fractures. Any other problem? Well, what's the plural? What's the plural effusion? Okay. What about this part? Well, that's what I'm asking. Anybody know? This is an extrapleural hematoma. Okay. And the way you notice that is there's this fat. This is displaced extrapleural fat. So this is not blood in the pleural space. This is in the extrapleural space. So these are associated with rib fractures. If they have convex margins, often they're associated with injury to the intercostal artery. Okay, they can get bigger over time. The treatment for this is not a chest tube, because the chest tube in the pleural space is not going to address this. This is in the extrapleural space. So if these get enlarged, then it may require embolization of the bleeding site to be able to control the bleeding. So that is an extrapleural hematoma. You want to be able to differentiate that from a hemothorax. Okay. So here's the displaced extrapleural fat. That hematoma is outside of that, commonly, almost always associated with rib fractures. Okay. Another example, you can see the high density here, the displaced extrapleural fat here and here. So this hematoma is not in the pleural space, that is an extrapleural hematoma. Here on this coronal recon, very nicely demonstrated, that is an extrapleural hematoma here in the rib fractures. This patient's had a motor vehicle accident. The trauma team looks at the CT scan, comes to you and says, well, here's the trachea, here's the esophagus. Does this patient have airway injury? What's going on here? What is that? Anybody? No, it's not. That's the point. It's not an esophageal perforation. So this is called what? This is a tracheal diverticulum. These are very common. Often we overlook these, but start looking for these on CT scans. You'll see these very commonly. It's not that, and then, it's usually one of those things that you don't notice until somebody points it out, and they'll always point it out, and you'll confuse it with something terrible. You don't want to do that, okay? So this is a tracheal diverticulum. These occur at the thoracic inlet, and they occur here towards the right side. Look for these on your CT scans. You will see these very commonly. This is unusual in that we can actually see the opening. In most cases, you don't see the opening of the tracheal diverticulum. So that is a tracheal diverticulum. So realize what that looks like. Okay. So don't confuse that for pneumomediastinum. Don't confuse that for injury to the esophagus or the trachea. Patient had a motor vehicle accident. We look at this at the chest radiograph and we say, what?
What mediastinum?
Wide mediastinum. So what are we worried about?
Dissection.
Not dissection. The term is not dissection. What's the term? Traumatic aortic injury. Okay. Specifically if, there are many causes of widening of the mediastinum, but especially if the aortic knob is obscured and you get widening of the mediastinum towards the left side, then that's associated with what you're looking at is hematoma in the mediastinum from injury to the aorta, and the term for that is traumatic aortic injury, or TAI. So all of this represents hematoma here within the mediastinum, and in almost all cases we can actually see on CT the injured part of the thoracic aorta. So you'll see the internal irregularity, and so that's where the tear is within the aorta, and then there's bleeding outside of the aorta. So that's traumatic aortic injury. Okay, the hematoma here can extend down pretty far. It can extend all the way down into the abdomen in these cases of traumatic aortic injury. And then here's another example. So, there's confusion in the terminology. When you call this dissection, you call this pseudoinjury. So the term now is traumatic aortic injury when we see these tears of the aorta associated with trauma. So another patient who's had motor vehicle accident, and you can see there the most common location for this is at the insertion of the ligamentum arteriosum, and you can see that little outpouching there. But what's also important is that little bit of blood. So that tells you that this is not a tracheal, this is not a diverticulum, a ductus diverticulum, that this is blood. And so this is a traumatic aortic injury for this patient. Okay? And then here it is on the reconstructive views, and how is this usually treated? Yeah, so this is now treated for quite a while with this stent graft. By the way, notice that this stent does what? It covers the left subclavian. This patient has a nice variant of the anatomy that was actually beneficial. What is that? Yeah, bovine arch. So patients can survive if you cover the left subclavian artery from collateral flow. You don't want to cover the left common carotid artery. If in cases where they do, they might have to do a bypass to maintain flow. But because of the bovine arch, this originates more proximal, so that gives more of a landing zone, a bigger landing zone for the stent. Okay. So another patient here, a traumatic aortic injury. You can see the injury, you can see the hematoma there in the mediastinum. Here's the injury, there's the hematoma. So this patient was also treated with the stent. And then here, when we look at the great vessels here, and axial images, and on this coronal image, we notice what? Yeah, there's thrombus in the left subclavian, right, because the stent is covering the left subclavian artery. So you can see that there's thrombus here in the proximal left subclavian artery. okay? So again, if you cover the subclavian, remember there's collateral flow from the vertebral that can maintain patency, and other collaterals also can form that maintain patency of the subclavian artery. The stent also looks like it's covering, so what's the next vessel, just proximal to the subclavian? That would be where? Left common carotid. So is the stent covering the left common carotid artery too? Yes, no?
The last liner is not covered.
Correct. So with these stents, the prongs, the most proximal prongs are not covered. So those prongs can go over a vessel and will not occlude the vessel. Okay? So, don't make the mistake of saying that, oh, the stent graft is covering the carotid artery, right? So the proximal prongs are usually not covered, so they can place that over a vessel and it will not occlude the vessel. Okay? Another patient with motor vehicle accident. This is a ductus diverticulum, right? Here there's no hematoma, it's very smooth. This is a ductus diverticulum. Do not mistake this for injury to the aorta. Okay? So almost always there will be hematoma associated with that. Another patient with motor vehicle accident. What do we have here? And what's the significance? Yeah, so here there is an intimal irregularity, okay, but there is no hematoma. There's no hematoma in the mediastinum outside of the aorta. So this is called minimal aortic injury. And what is the significance of this in terms of treatment? Yeah, it can get follow-up. This can be treated conservatively, does not require intervention. You get follow-up to make sure that it is not progressing. So that's minimal aortic injury. So we have an intimal flap, or sometimes even a clot, no irregularity of the aortic contour, no intramural hematoma, no mediastinal hematoma. That can be treated non-operatively. We just get follow-up studies to show that it is not progressing. So that is minimal aortic injury. Okay? This is, by the way, more images on the patient with minimal aortic injury. You can see the not so minimal in terms of other injuries. You can see the sternal fractures. Another thing on your coronal images, look at the costochondral junctions, right? Because these fractures of the anterior costochondral junctions, very hard to see on your axial images. So when you're looking at your other images, when you're looking at your coronal images, look at the sternum and look at these anterior costochondral junctions. This is where you will pick up these injuries to the cartilage at the costochondral junctions on your coronal images. So look for this. Make this part of your checklist on all patients who've had severe trauma. Okay. Another example, motor vehicle accident. What do we have here? Well, the first thing we always look for is hematoma. Is there hematoma? Yes. Where is it? Your intrasternal. So there's hematoma here in the anterior mediastinum. Is this hematoma because of vascular injury? Well, not from injury to the aorta, right? You see that it's not. There are nice fat planes between that and the aorta. So what can you attribute that to then? Yeah, it might be bleeding. Well, internal mammary bleeding can do that, right? That can do that. But is there another injury here that's demonstrated? Yeah, there's a big fracture out here. Okay? So you can see that big fracture there, which is called hematoma. So,
wait, like behind the.
yeah.
So on the upper left image, upper right, sorry.
Yeah.
Behind the sternum.
Yeah.
Like on the upper right.
Here?
Yeah, like is
Yeah.
that like could that be like active extra or something there? Just,
Yeah, they did. Well, these were vessels. This was not extravasation on this particular side. Okay. All right. So when there's hematoma in the mediastinum, you want to determine, is this hematoma from injury to the aorta or is this hematoma from injury to something else? So whenever there's hematoma that you see in the mediastinum, look very carefully for signs of injury. What's causing the hematoma? Okay. So in this case, the injury there, that can occur So these injuries can occur very close to the internal mammary artery. You can always get bleeding from the internal mammary artery that can cause large hematomas. And again, let's see all the injuries to the ribs and everything else. Reformatted images here. Is there a fracture on this image?
I'd like to see the performance, but yeah.
Where's the fracture? Yeah, sure. And sternum looks irregular. Okay. So sternal fractures very, very easy to miss on your axial images. It's very easy to miss sternal fractures. Always, go to your sagittal images. I actually like, in trauma cases, I actually like to look at the sagittal images first, to look at the spine and look at the sternum, because if there's injury to the spine or the sternum, then I know, boy, this is severe trauma. This really requires a close look at everything. Okay. So I actually like to look at my sagittal images first. But this is where you're going to pick up injuries to the thoracic spine and injuries and fractures of the sternum. Sternal fractures notoriously very easily missed on axial views. Is this a sternal fracture? No. Yes, no. So what is this? Yeah. So what happens here? This is kind of a fake out, and notice that there's discontinuity also in the skin. So what happens is if there's breathing motion, then this part, there's misregistration between here and here, and so you'll have this offset, which is not a fracture but an artifact of the imaging. When the patient is breathing, the spine stands still, so you're not going to see an artifact there in the spine. The artifact will occur more anteriorly. Another thing that can happen is often there's a delay. The way the protocols are set up, there can be a delay between the end of the chest and the beginning of the abdomen, right? We like to do the abdomen in portovenous phase. We like to do the chest more in the arterial phase. So because of that delay, there can be misregistration there. So look at the skin here, and you can see that, okay, that's not a fracture. That's just an artifact from the imaging. Okay, so you don't want to get fooled by that fake out. Another patient here who's had trauma, chest pain. What can you tell me about this? Well, the first thing is there hematoma? Where? Okay, so there is some increased soft tissue stent density here behind the sternum, right? So there's some hematoma there. Right? So there still looks like there's a fat plane between that and the aorta and the vessels. So this is probably not then from aortic injury. So again, aortic injury, the hematomas tend to be more around the aorta, right? So you want to take a close look here, right? Take a close look at the sternum. And this is the sagittal images, right? See how easy this is to miss on your axial images, all right? So these sternal injuries, very easy to miss on axial images. Always look at your sag. You can see the complete dissociation here between the manubrium and the sternum, which is causing that hematoma. Okay? Another patient with chest pain. So first question, is there hematoma? Yes. It's an anterior mediastinum. And is there anything else? Yeah. So, of course, whenever there's hematoma, you want to look very carefully for any active bleeding, right? Are there collections of contrast where they don't belong? Okay, so here there's hematoma back here, and then here you can see that blush, these extra patchy areas of contrast. So this could be, you have internal mammary artery, internal mammary vein, all the vessels that run back there behind the sternum, but there's active bleeding here in this patient that is causing that hematoma. So you don't want to miss that on the CT scan. So whenever there's hematoma, look for injuries, look for any evidence of extravasation. Okay. And so you can see here the blush, and then nice big injury there in the sternum in this case. This patient, another patient with hematoma, this is in the posterior mediastinum, so this hematoma is from the fracture of the thoracic vertebrae, right? So this can also cause hematoma. Sagittal images, very useful for telling you, boy, this patient's had severe trauma. Status post-motor vehicle accident, chest x-ray looks like this. What's the problem here?
There's emphysema in the chest.
Yeah, there's a large amount of emphysema in the chest. There's a large air leak, okay? So if there's a large air leak in a patient with trauma, what are we concerned about?
The patient's intubated, so it could be also viral trauma.
Yeah, so injury to the airway. Okay, so if you have a large air leak, don't worry about injury to the airway. You can see here that airway cartilage has been disrupted. So we have all of that air that's leaking out into the patient's soft tissues. So whenever there's a large air leak, you want to look for injuries to the airway. Disruption here. Another patient with a massive air leak, this is because the tracheostomy tube got dislodged and was sitting in the subcutaneous soft tissues hooked up to a ventilator. Okay. So that caused a massive, here when you fix it, that's what it's supposed to look like, without all the excess of air. Okay. Patient had a motor vehicle accident, we see some funny looking opacity there on the chest. Here on the CT, we have a pneumothorax. So what is this stuff? That's contusion. Notice that there are rib fractures. So what happens when the lung mashes up against the chest wall, you get these contusions in the periphery of the lung. So these peripheral consolidations, peripheral areas of ground glass opacity, especially in patients with rib fractures, these represent pulmonary contusions. Okay? Another example, you have this ground glass opacity in the periphery, rib fracture, that's going to be a pulmonary contusion. Another patient with motor vehicle accident, what do we call this? What's happening here? Yeah, so the consolidations here then represent, this is hemothorax, but the consolidations in the lung actually represent bleeding, hemorrhage into the lung. And these irregular collections of air, these are pulmonary lacerations, right? So these are not contusions, these are pulmonary lacerations, actual tears in the lung parenchyma that causes the hemorrhage and the bleeding, and so the consolidations that we see are actually blood in the lung parenchyma. So those are pulmonary lacerations. Here, this patient has what? Yeah, this is a big hemothorax. Easy to recognize in this case, especially on this non-contrast image, because of the high attenuation. Right? So sometimes you can get a layering effect, a hematocrit effect, but high attenuation pleural fluid is a sign of hemothorax. Okay? So that's another example here of, you saw this earlier, this is extrapleural hematoma. Notice the displaced extrapleural fat. This chest tube will not drain the extrapleural hematoma because that's not in the pleural space. What about this? Yeah, so why do you suspect diaphragmatic injury? Yeah, you have bowel gas here on the left hemithorax, the heart's displaced to the right. So here you worry about diaphragmatic injury. Anytime you see air collections like that within the chest, you worry about diaphragmatic injury. So here all of this bowel is herniated up into the chest from diaphragmatic injury. Okay. Another example here, this one happens to be on the right side. Liver's herniating up along with some bowel from diaphragmatic injury. So here you can see the bowel herniating up into the right hemithorax on the injury. On the coronal views, there you see that very nicely demonstrated. If there's an NG tube and the NG tube goes up into the chest, another sign of diaphragmatic injury. Okay. So there's the stomach up there into the chest from the injured diaphragm. So signs associated with diaphragmatic injury, what's called a dependent viscera sign. Usually there's a little bit of air between the liver and the spleen, but if there's diaphragmatic injury, you can get what's called a dependent viscera. So the stomach even kind of drops back posteriorly. So in the axial images, the dependent viscera sign can be a sign of diaphragmatic injury. But now we have, look at your coronal and sagittal views, is another example of the suicide injuries, bowel, up here in the chest. What kind of trauma did this patient have? Yeah. So here you can see a tract of hematoma actually going through the lung. So either gunshot wound or stab wound. Okay, so that's penetrating trauma when you see tracts like that extending through the lung. Pneumothorax here, and you can see the hematocrit effect too. And this patient, you can see the bullet. There's the tract going through the lung. Actually, ET2 is the right main bronchus also in this patient. Stab wound. What are we worried about here? Chemopericardium. Yeah. Look at the size of that cardiac shadow. Big pericardial effusion in this patient. Another patient with a stab wound. There's what's causing the mediastinal. Remember, anytime you see hematoma, you got to explain it. What's causing it? Do you see the injury? Yeah, this thing's sticking off the aorta, right? So there's a tear there in the aorta from the stab wound. That's mediastinal hematoma from injury to the aorta. Okay. What about this? So this is not trauma. No history of trauma here. Hello? No history of trauma. What's the problem? What's that normal? Yeah, so there, what do we call this? What do we call this? Well, this is the mediastinum, and there's air in the mediastinum. We call it pneumomediastinum. This patient has pneumomediastinum. So what's usually back here? Usually pneumomediastinum. Also some small pleural effusion. What would you be concerned about? Borhaus. Yes. So this is a patient with history of vomiting. This is Borhaus. Right? So pneumomediastinum, pleural effusions, patient with no history of trauma. You worry about, ask about any history of vomiting. Could this be Borhaus? This was a case of Borhaus. Actually, a wide mediastinum. Here's an even worse case. This patient was found unconscious in the bathroom. Has a large left pleural effusion. There's also air, right? So there's also a pneumothorax there on the left side. So they did a CT after giving oral contrast, and you can see the contrast is actually extravasating out into the pleural space from the esophageal tear, and then the rest of that is mediastinum from Borhaus into the esophagus. Okay. All right. So that's it for today.